We're going to continue with the speakers as, on the schedule, and our next speaker is one of our awesome orthopedic surgeons from here at the Shriners Hospital. She's been here since 2011.
On and off, yes, since 2011.
Yeah, since 2011, and she works very closely with the rickets, our genetic rickets clinic when our kids do need some surgical procedures. But she also works with all the different patients from within the Shriners Hospital for other issues as well, because the Shriners Hospital here is a mainly orthopedic rare disease hospital. And this is Dr. Lindsay Stephenson, and she's going to present surgical intervention in X-linked hypophosphatemia.
Good morning. As Dr. Ruby said, I've been at this facility intermittently since 2011 and full-time since 2014. So today I wanted to talk a little bit about my role as a pediatric orthopedic surgeon in part of the team taking care of our pediatric patients with XLH. So Dr. Ruby has very well gone through this, but you know, as an orthopedic surgeon, we have kind of a basic understanding of what's going on, but I have to emphasize the word basic. And as we know, the bone changes are secondary to renal phosphate wasting. And if you see up there, secondary is highlighted. Again, I have to emphasize that my role in this team is very much secondary to the endocrinologist taking care of the child. We talked about expression in the osteoblast of that FGF23 product, and that inhibits the phosphate reabsorption and leads to hypophosphatemia. And so the radiograph you see there is a pretty typical radiograph and is actually one of our patients. And you can see our typical findings that we look at. So what's the role of the orthopedic surgeon? As we're all aware, most of our patients present with short stature, generally 2 standard deviations below the age expected mean. We have limb angulations, and that's where we are very much active in management. Mostly varus, sometimes valgus, and sometimes windswept deformities. There's often internal tibial torsion, which you can see in this patient, both varus and internal tibial torsion. Radiographs, what we look for are the irregular physes that are widened and cupped. We see a metaphyseal osteopenia, and we see widening and flaring of that periphyseal and periarticular region. So what we know and what we rely on is medical management, because good medical management improves outcomes. As we know, the defect in mineralization is still present, and we rely on this balance of phosphate and vitamin D. And as we were talking about in the last talk, the KFOS and CALS trial are mainstays of treatment. So orthopedic view of medical therapy is really pretty simple. Medical therapy improves bowing, which decreases surgical opportunities. That's good and bad. Good for the patient, bad for business. I mean, simply put. But you know, I definitely think I should have made the green much bigger than the red, because I think minimizing surgical intervention is always in the best interest. Improves growth and attained height. And treatment's guided by clinical outcomes. So as Dr. Ruby was talking about, goal is not always correction of the serum phosphorus. And we rely on kind of a cohesive dialogue to decide when and if surgical intervention is needed and what the timing should be. So medical therapy in adults. Why should we continue therapy into adulthood? You know, bone pain is not something that we like to hear about, and that's not just in our XLH populations. I take care of a lot of the pediatric osteoporotic conditions. The most common one at this facility is osteogenesis imperfecta, which is also another group that has a lot of bone pain. We also want to decrease the incidence of insufficiency fractures. It may help with decreasing the time to fracture union and reducing the risk of prosthetic joint aseptic loosening. So what are the proposed benefits of surgery? Prevention of bone pain. Like I said, bone pain is a big problem with a decreased quality of life. We would like to prevent fracture, which again decreases quality of life and increases surgical burden, and then prevention of degenerative arthropathy. Again, the same thing as fractures. So bone deformity. As an orthopedic surgeon, we often get consulted for children with bowing. There's a large spectrum of bowing. It is expected and physiologically normal for children to be born bow-legged. That's due to intrauterine packaging, and we expect that through really the first 2 years of life to see bowing. So how do we differentiate what we call physiologic varus from pathologic varus? Well, first of all, pathologic varus, unless there's a strong family history or other reason to suspect it, really will not be diagnosed before 2 years of age. And in fact, here we don't take radiographs prior to 2 years of age because we're not really sure what to do with the findings, because some of the changes that you see less than 2 years of age may or may not be indicative of a pathologic condition. So we have our physiologic versus our pathologic varus. So as long as the varus resolves by age 2, it was physiologic, not a problem. Pathologic varus. How do I decide the child that comes in that has bow legs, that's 3 years old, how do I start thinking about them? The first thing I do is look at stature. If they're normal or tall, I, in my mind, put a rickets, XLH, bone dysplasia much lower on the list. If they're less than the 10th percentile in height, I start thinking about skeletal dysplasias and metabolic bone diseases. So I have 2 different deformities which produce the same, or not same, similar clinical picture of bowing. So, but really when you look at them closely, you can see how different they really are. So the patient over there has this nice, smooth, symmetric bowing of her legs. You can't look at the leg and say, oh, there it is, it's right there. You just kind of look at it and say, oh, it's nice and smooth. Versus this patient here. It's right there. You can look at it and say, it's right there. And their radiographs show that too. You can see in this patient right here. Here's the problem. This is a secondary problem, but here's the problem. First, it's looking at the radiographs over there, and you see that kind of nice, smooth bowing. So those 2 conditions that I'm looking at are XLH versus Blount disease. So how do we compare these? So Blount disease, by definition, is varus. XLH, we see varus most often, but sometimes we see valgus, and like I said, sometimes we see a windswept deformity where one leg is in varus and one leg is in valgus. The deformity apex, or how we think about it from a surgical planning standpoint, is the XLH deformity is multi-apical. Again, leading to that nice, smooth bowing that we see. There are many points of deformity along that bone. That actually makes our job a lot harder because to correct the deformity, we want to cut the bone at the apex of the deformity. But if you have infinitely many apices, where do you cut? It's difficult. Versus Blount's disease is, by definition, it is a problem at the proximal medial tibial physis. Again, patient stature. When I see them walking down the hall, one thing I look for is kind of the quality of the bowing. Sometimes I can't tell, but what I can tell is look and how they compare to the rest of the children standing around them that are of similar age. If they're shorter, I'm immediately in thinking I need to get radiographs and metabolic labs because I'm concerned that they have a skeletal dysplasia and or a metabolic bone disease. If they're at least average height or taller, I'm more likely leaning towards Blount's. Both conditions demonstrate internal tibial torsion. Genetic mutation, there is none in Blount's disease. So it's not heritable per se, although it does run in families, but we haven't identified exactly what causes that. The other thing I would say, in general, children who present with Blount disease, like we saw in this last picture, not only are they generally tall, they're generally obese children. And it's unfortunate that a lot of times they're like, oh, well, they're also tall. Well, yes, but they're still obese for their height. Versus our children with XLH, we don't see the prevalence of obesity that we see in the Blount's population. So surgical options, there's a lot. So I kind of went through a little bit of a surgical history, which many of you sitting in this room have lived through these things, and we'll kind of talk about about where we were and where we are. And honestly, I think where we are right now is pretty good. I'm not sure where we can improve on, short of metabolic control and maybe even genetic control of the disease. So external fixators, and I brought, like I said, some of you, this may be PTSD for some people. So we use these still when we need to. So external fixators, there are many techniques. This is a picture of an Elizaroff frame. This is a Taylor spatial frame, which was the next generation, and this allows multi-axial correction. So it's a lot more forgiving for the user than this kind of single axis correction that you can get with the Elizaroff frame. You can make it multi-axial by adding hinges, and that's just a much more technically demanding surgery. In this picture, you can see that this is actually a combined technique where you have a frame and you have intramedullary nails. The thought behind that is that, one, you may be able to get rid of the fixator sooner because you do have some internal support to the bones, and then two, this may prevent against bending of the regenerate and further deformity. So in this study, they talked about simultaneously correcting both the femur and the tibia with these circular frames, as well as adding the supplemental intramedullary fixation. In their paper, they did not find any recurrent deformities in the parts of the bone that were protected by the intramedullary nails. They did, however, find a high rate of recurrence of deformity. So here's another article that kind of demonstrates some older fixation methods in the middle with the K-wires and pins and plaster. Again, some people very much remember pins and plaster. I trained in a time where we still use pins a lot, but we don't use them with plaster per se, meaning that we have better fixation tools and devices to use. So we don't need the supplemental plaster fixation. All the way over on my right is intramedullary nail fixation. Those are locked nails as opposed to the nails in the prior picture. Those were flexible nails. Locked intramedullary nails are an option for our adolescents. They are not a good option for our very young children. Technology and bravado in the orthopedic surgeon is increasing, and we now are placing these locked solid nails in children probably as young as 10. It used to be 12, and before that it was probably 14 or skeletally mature, so that number keeps trending down. There are people even pushing the envelope at 8 or 9 years of age. There are some biologic implications of placing these nails inside the bone, mainly of the growth plates and apophyses. The tibia has not been as aggressively used in younger children as the femoral nail, but those are options that we have and still use today. And then of course this is a picture of an external fixator. This is a massive Elizaroff construct encompassing the entire leg. And even with these methods, and with excellent radiographic results, their follow-up showed a 90% recurrence rate after the first procedure, and even a 60% recurrence rate after the second procedure. I think some of the caveat of this is older data and older surgical technology, as well as older medical management. And I think that may be the underlying theme here in these high rates of recurrence. We talked a little bit about the fact that a windswept deformity can be present. So there's some different examples of windswept deformities, and then again the massive Elizaroff device to correct that. And you can see just looking at the radiographs how intimidating this is just to look at, and I know many people have lived through that, and kind of the paradigm now in pediatric orthopedic surgery and deformity correction is shifting away from these devices. So when Elizaroff first brought his ideas of distraction histiogenesis or distraction osteogenesis, it was a revolution. And then Taylor brought us the hexapod fixation that allows so many degrees of freedom, and this is computer generated. It has recently come off patent, and so now there are some competitor products as well. Similar idea of this hexapod platform. What has sparked the revolution in deformity correction, and really where it sparked was in limb lengthening, is now we have magnetic intramedullary nails. This is an example. It looks just like a regular nail. This is a nail that can grow. This nail is actually distracted, I believe, 5 centimeters, but this nail can grow 8 centimeters from the time I put it in till the time it's done growing. And so with the advent of this technology, the paradigm has shifted to avoiding external fixators. We still use them sometimes in the operating room to help us do surgery, but the goal is for a patient to not have to see that external fixator ever. So we've recently had this paradigm shift in that segment of orthopedic surgery. We've had a revolution too in management of our pediatric patients, because again, this is an intramedullary nail and there are some limitations not only in the age of the patient, but the size of the bone, both in length and diameter. The company that makes this is Precise. It's called Precise Nail. It's made by Ellipse Technology, and they have done a lot of work to continue to bring us nails that are shorter so that we don't have to have such a long initial length, and they also have been working on getting us narrower diameter nails. However, the narrowest diameter they have is 8.5 millimeters. And in order to place this nail and use it successfully, you really need to prepare the bone to a diameter of 10.5 millimeters. And while that doesn't seem very big, when you're dealing with young children, that's giant. And that makes the procedure not feasible. So what is this revolution that I have on the screen? The revolution is the idea of guided growth. Is guided growth new? No, not at all. These are actually pictures of Blount's staples. Again, we talked about Blount's disease earlier as a common pediatric bowing condition. These Blount staples, though, while they worked, they didn't work great. I don't know if you can tell in the pictures, often you have to put multiple, 2 to 3 in at each site. And they literally are metal staples, so not like the one that holds your paper together, but if you do any carpentry and those kind of, they are just staples, just that. They're just industrial strength. They don't stay in the bone very well, and that's the biggest problem we have with them and why multiple were placed. But again, if it doesn't stay in the bone very well and you put 3 in from front to back in the growth plate and only the back one stays in, you can imagine you're only holding one little corner of the growth plate and the rest of it can grow around those staples. So that's proved to be kind of the downfall of using these staples, is that they come out, you don't get the correction you want, you need growth for this process to work. You're relying on restraining one side of the growth plate while the other side grows. So you can imagine that actually creates some issues in patients with metabolic bone disease and skeletal dysplasias, because they don't grow that much, right? We've already talked about our final attained height, is less than expected. So if you lose your ability to hold one side of the growth plate, then you've lost very valuable time. I have actually not used these staples for this indication. I have used these staples in other indications, but I've also been on the other end of looking for a migrated staple. Those guys are really hard to find. So when one comes out, it is very much an expedition to go and find it, and it's actually probably more morbid of a procedure to go and find a dislodged staple than it is to put it in. And probably is not the right word. It is absolutely much more morbid. But this was the revolution. This is the paradigm shift that in 2006, and you'll notice the name Peter Stevens there on the citation. So 2006, Peter Stevens talking about using growth manipulation as kind of the general term for harnessing the power of the growth plate and using it in hypophosphatemic rickets. Well, look again, we have Peter Stevens in 2007. And what Peter Stevens brought to us in 2007 was the idea of this tension band plate. I just spent several minutes telling you how bad these staples were, although they are not the worst thing in the world, but they needed to be improved upon, and this is the improvement. So what's better about this? These guys don't migrate as much. I won't say that they don't move, because they do. We still have issues with them growing off the physis. We still have issues with implant breakage. We still have issues, but it's so much better. So that in 2007, we had this great revolution of not only knowing that we can use growth manipulation, but now we have an implant that works better. So these implants, I mean, I can't believe it took us that long as an orthopedic community to figure that out, because these implants are not impressive at all. They aren't. I mean, so there are several companies that make these plates. This is actually the initial design of Peter Stevens. They make a smaller plate than this, but I don't have it with me. But they're just little plates. And he called them 8 plates. That's the proprietary name from Peter Stevens, because it looks like a figure of 8. So it's a plate with 2 holes. These are titanium. These are color-coded. And the thing that goes with them are one of these 3 screws. So orthopedic surgeons generally talk in lengths. Oral maxillofacial surgeons generally talk in colors of screws. So we feel a little bit like them. So green screw, the purple screw is the real short screw, that's 16 millimeters. This is 24, and this is 32. So this little thing that you can carry around in your pocket in the state for change, pocket change, caused a huge change in the management of our patients. Again, this is more proof of concept paper by Peter Stevens and his results and what he was able to accomplish in taking, for example, figure C to figure E. I'll have to say that there was a Houston connection in publishing about using the technique and comparing the plates to the staples here at this facility. And my predecessor, who took care of many of our skeletal dysplasia, metabolic bone disease patients in terms of managing their osteotomies, was Dr. Urquhart, who's the second author on this paper. And he really taught me most of what I know in this field. So I do owe him a debt of gratitude, as do many of us, due to his work in publishing this information. Again, people looking, Peter Stevens again, the following year, 2008, looking at what we're calling guided growth or growth manipulation in pathologic physes, because he definitely got some backlash in the community saying, well, that's all well and good when the kid's growing normally and it's just for what we call idiopathic genu-varum or genu-valgum. And again, proof of concept that, and this is actually a XLH patient from his paper, who just happened to have valgus instead of varus. Again, it happens just not as frequently, nicely correcting their deformity. Other people have looked and said, okay, that's great, you've proven that it works in these growth plates that are not growing as expected, but what does that mean? Clearly it doesn't work exactly the same. And they were right, it doesn't work exactly the same. If you look at the first circle to my right, everybody achieved complete correction in that group of patients, and those are the patients with idiopathic deformities whose growth plates grow as normal as we can expect them to. We can't find a defined abnormality. But when you look at the patients with pathologic growth plates, and that was just a all-comers group of skeletal dysplasias and metabolic bone diseases, you can see that there is a failure rate. They didn't do statistics, but you have 6 patients in that total of 58 that didn't correct, and they were all in the pathologic physes. The next thing you can look at is you can see the age at which the plates were put in was much younger. And again, that's because we know we need growth. And if our growth potential is less, then we need to start sooner. So growth manipulation, how do we use it here? We're pretty aggressive with our patients, I think, and I think for a lot of reasons. I think preventing the deformity from getting out of hand. I think once we get a neutral mechanical axis, once we get a neutral alignment, we have a better chance of maintaining a neutral alignment, especially in the setting of excellent metabolic control. So where can we intervene? So one place we intervene is at the hip, and specifically that's the greater trochanter, and that's called the greater trochanteric apophysis. And so in some patients who have coxa so that bending of the neck, which is produces the waddling gait that many people complain about and dislike, That waddling gait is because the muscles that run from the pelvis to the hip right here, your hip abductors, they are designed to be at a certain length. Now, when you take the femoral neck and make it varus, that shortens the length. And so their moment arm is much reduced. They no longer have a mechanical advantage. And so that's why you see many people with a waddling gait. If you take an x-ray of their pelvis, you will see that their hips are in varus. So intervention here needs to be done early. We have found the kids, once they get much over 5 or 6, putting a screw in the apophysis there probably stops the varus from getting worse, but we have not seen that there's been a lot of correction there either, so you just kind of hold it where it's at. This is something that has not been looked at in the literature and is perhaps an area we can review further to decide who should have intervention, who shouldn't, when should they have it, because there are some children we see at 3 years old and their femoral necks look like that, and they have excellent metabolic control, and the next time we see their x-ray of their pelvis, their hips look more normal. The next site that we can intervene at is around the knee. Depending on your deformity, if you're in valgus, we intervene on the inside of the knee or the medial side of the knee. If you're in varus, we intervene on the outside of the knee, at both the distal femur and the proximal tibia growth plates. Those are the most active growth plates in the leg, right around the knee there. So that's where the bulk of our work is done. The other thing that people have become more aware of is the ankle varus. Just getting the knee straight is not enough. We need to address the ankle, and so we've become somewhat aggressive as well addressing the ankle. The problem with the growth plates around the ankle is they don't grow a lot. So again, you need early intervention there. You have 2 places to intervene here. You have the distal tibia and the distal fibula. So we'll have some examples of that. So this is how these go in. It may look barbaric, but actually the incisions are very small. An incision an inch or so can get these plates in. There's a plate down at the ankle, and then a screw down at the distal fibula. So all of those things we can use to restrain the growth on the outside of the leg, which is effectively longer when you're in varus, and let the inside of the leg catch up. What happens when it catches up? We take the plates out. What do we do when we take the plates out? We cross our fingers and hope that the deformity doesn't come back. And we plead with the patients to please don't skip your endocrine appointment. Please take all of your medication, because we know that without that we will fail. We will ultimately be back and trying to use growth manipulation again if they're young enough, or we go on to kind of the things that we saw earlier, the osteotomies with the nails and plates and external fixators. What are our goals? You can look at the lower extremity, and you would like to have what we call our weight-bearing line that passes from the center of our hips to the center of our ankles, go through the middle of the knee. So you have zone 1 on this lateral side of the knee. You also have a zone 1 on the other side of the knee. You want it there. You want it central in the knee. The other way to look at it is to measure joint angles. It's not as simple as that, though, because we talked about the fact that this deformity is multi-apical. So sometimes we see that while we have the weight-bearing line going through the knee, you'll see that the bones are a little bit S-shaped. As a pediatric orthopedist, that doesn't bother us too much. It does make our joint replacement surgeons a little bit crazy if they have to use specialized implants, because it can make their job harder. But the way we look at it is that a small surgery with these plates and screws is much better than this surgery. And these really haven't been around long enough for us to know if that squiggle in the bone before you get to the joint, before you get to the knee, has negative implications or not. We think that it doesn't, and that's why we're not so aggressive in placing patients in external fixators any longer. One of the downfalls of growth manipulation is that while we are very good in managing the varus and valgus, growth manipulation is not so great in managing the tibial torsion, internal tibial torsion. There are people who have published results saying, yes, if you put your plate in a certain position, you can also influence the torsion. I think they think really highly of their surgical skills and their plates. I think that some of the natural history of the torsion is that if you correct the mechanical axis early, it gives the body time to naturally untwist, because that's what it would do anyhow. I think that having the deviated mechanical axis during that time when the body would naturally be untwisting stops that process. And that process for the tibia generally ends by age 8 to 10. Same thing with the femur, and that's probably on the long side. Some people would say even by age 6. So I think that's one of the reasons to intervene early, is to give the tibias a chance to untwist. The other thing that we see a lot of diaphyseal bowing that's not to the side, but it's to the front. Again, this surgery does not change that per se, but the same principle exists that exists for the torsion. That if you can get the mechanical axis where it's supposed to be, the bone is smart. It's connected to the brain somehow and knows how it wants to be. Orthopedic surgeons view the heart as just the organ to perfuse the bones. So we view the brain as the organ to tell the muscles what to do, but we don't look at it like cardiologists look at hearts or neurosurgeons look at brains. It solely exists to make the bones work. So the bone knows how it wants to be aligned, how it was designed to be aligned. And there's principles of positive and negative charges, the Heater-Volkmann principle, all of those things, but really it's just the bone knows what it wants to do. So I think if we can get them corrected young, I think a lot of that diaphyseal bowing, that kind of anterolateral bow that is so prominent in the thighs, does resolve as long as we get there early enough. So these are some of our patients from the hospital, just kind of a pictorial show and tell. A nice young lady who has all the classic radiographic findings and how her radiographs correlate to her clinical photos. And you can see we not only attacked her knees, but also at the ankle. Here the decision was made to not put a plate at the distal tibia here. And that's where she is now. Again, I said those plates don't change the bowing in the shaft. And you can see she has some bowing in her shaft, but if you take and draw her weight-bearing lines are where we want them to be. She was a little bit older when her procedure was done, so I don't know that we're going to get the resolution of the bowing in the shaft. But the main reason to do this, the reason you tell the insurance companies is not just aesthetics, right? Is because the joint reactive forces that are experienced by the cartilage of the knee, they're normalized when you have a mechanical axis that goes through the center part of the knee. When it's way out to the side, you're overloading one of the compartments. What happens when you overload the compartment? You get early degeneration, and then your knees hurt, and it's a problem. So while it's nice to have straight legs, and that's an added benefit here, really what we're doing is we're trying to save your knees from early joint replacement. Here's another child, and this child's case is a little bit confusing, so ignore the fact if you see that his left leg is bigger than the right. He does also have an additional diagnosis. But he presented initially just for that leg that was bigger. And over time, his mom said, he's had a couple of fractures, and oh, by the way, he's knock-kneed and it's getting worse. And we expect that, like I said, children, when they're born up until about age 2, we expect them to be bowed. Well, we expect them then to progress to being knock-kneed. And you should be maximally knock-kneed at age 4. And then by about age 7, you come to what is expected as typical alignment, which is just slightly knock-kneed. So you kind of go bowed, you go in, and then you drift back a little bit, but you stop kind of in that normal knock-kneed range. Well, this kid just kept going in and kept going in and kept getting worse. So his mom finally said something. And so finally, his diagnosis was confirmed at 10 years of age. So he had the same intervention. And now look where he is. So again, ignore the fact that the left leg is bigger. That's an additional diagnosis that complicates his story. But again, just a handful of small little things, small incisions, 2 surgeries, one to put it in, one to take him out. Day surgery, didn't even have to stay in the hospital. My protocol is you leave your dressings on for 5 days. After 5 days, you get to take them off, you get to shower. I don't let you swim or sit in the bathtub until I see you at about 2 to 3 weeks post-op, just to make sure everything's healed. This child actually lives in Mexico. I still made him come back at 2 to 3 weeks. The other thing that happens is, again, we're operating around the knee almost all the time for this patient population. Anytime you operate around the knees, the muscles, the quads, they go to sleep. They say, you've been too close to me and I don't like this, I'm taking a vacation. And so part of my protocol also is physical therapy in the hospital the day of surgery, because I want you up and walking around. No prolonged immobilization. You get crutches or a walker just for balance, but I want you doing your thing. The other thing I want you doing is I want you moving your knee, because I don't want you to get stiff. The last thing I want, which is really important, is our therapists teach quadriceps strengthening exercises to get those quads back on board. And that's really what I'm looking for at 2 to 3 weeks. I'm not really expecting to see wound problems. It happens very rarely. But what I'm really wanting to see is, are you doing your exercises? Are your quads coming back online? So that's kind of how we manage these my patients that have this growth manipulation procedure. So in the span of 3 years, that's how long it took for him to correct. So it's kind of a lot. I brought these and didn't show them while I was talking. So these are just regular plates that go outside the bone. Here is an intramedullary nail. This one doesn't grow. Here are some of the intramedullary nail options we have for really small children. They're not typically used in children with rickets because we luckily don't have the fracture issues like we have in our osteogenesis imperfecta patient population. But these are nails specifically designed for children with very small bones that are growing. They come apart in 2 pieces. The benefit of that protocol that I just talked about, walking, moving your knee, before when we did osteotomies and we said you can't walk on it and oh, by the way, we're going to put you in a cast, that wreaked havoc on our metabolic control. And we looked back at our endocrinologist and we said, you know, there may be a problem with calcium mobilization because we're immobilizing the patient for 3 months, 6 months. And so it kind of made it really hard for them to do their medications when we're like, oh yeah, we're going to throw this wrench in here. And then when it takes a long time to heal, then we look back at our endocrinologist and we're like, what's going on? Like, come on, guys. And so these advances that we've seen in our, not only our implant technology, but our surgical technology, and so has really kind of changed where we are in managing pediatric patients. So I think we're pretty good now where we are surgically, and I've thought about how can we make this better. I'm not really sure. I mean, I would like to think that we could develop a smart implant because we have a smart everything now. We have smart TVs and smartphones and smart fridges that knows to untether itself when it's done its job. I'm just not sure how to go about telling that implant when it's done its job. But maybe it's like this magnetic nail. Maybe there's an on-off magnet I can use to say tether and untether, and that would reduce the number of repeat surgical interventions for patients. Do I see that on the horizon anytime soon? No, but maybe some point in my lifetime I can think about that. Although I was told when I was in elementary school we would have flying cars by the year 2000. So far, we don't. So, but we can dream and hope about those things. So I wanted to leave plenty of time for questions. So thank you.
I got a question. Is it working?
I hope so. Try to speak loudly in case. We can hear you.
Well, I know that you do a lot of the surgeries and stuff on the legs and everything, but what about the arms, the blowing of the arms?
So, you know, it's the same discussion that we have in all of the kids that we take care of. The functional tasks of the legs and the arms are very different. So, the legs primarily are there for gait, and there's a very well-defined pattern of how gait should look. It's one of the struggles in upper extremity research is that if I ask all of you to do some upper extremity task, put your hair in a ponytail, you will see, you know, 50 different ways to do it. And it's because there's no defined cycle in which the upper extremity should go through to accomplish tasks. The other difference is for most of us, our shoulder has a lot more range of motion than our hip. And that's by osteology, by design. So you have a lot more compensatory motions in your upper extremity than you do in your lower extremity. When you add that to the fact that there's no defined correct way to do it, there's no defined cycle, intervening in the upper extremity is not done as frequently. Now we know from the osteogenesis imperfecta world that when you have bowing deformities greater than 30 degrees, you have decreased quality of life, decreased upper extremity function. We generally don't see that kind of deformity in the XLH population. A lot of that is also, again, by design. You walk on your legs, you don't walk on your arms. Part of what happens with the bowing is that once you get bowed, then you load the bone. The biomechanics promotes bowing, right? So then you keep loading the bone with the mechanical axis offset to the inside of the knee, and the leg bows more, and the leg bows more. So until you fix that, you're going to keep having progressive bowing. We don't see that in the upper extremities unless you really are walking around on your hands. So there is not a lot of intervention, and in fact, in all of the orthopedic literature, there is no study talking about intervention for bowing of the upper extremities, specifically in the XLH population. Yes?
So this has been a wonderful presentation. How widely taught are these procedures?
So, growth manipulation is a common procedure. Even people who aren't pediatric orthopedists may employ it. Technically, it's not a very demanding procedure at all. It's very easy to perform. The hard part is, and for most of pediatric orthopedics, the hard part is when do you intervene? You know, it's very different than the arm is broke, I need to fix it. That's very clear when you intervene, right? It's broken, fix. Watching children grow, knowing how much growth they have left. We have certain standards that work for typically growing children, but those are kind of even off because that's based on data from Boston in the 1930s and 40s, and certainly are, as a society as a whole, we don't grow like we did in the 30s and 40s, and that was predominantly Caucasian children of Irish descent. And certainly our society is much more of a melting pot now. So even those numbers may not be accurate what we use for our typically developing children. So how do you predict all of this is kind of the art of all of this. So does everybody know how to put this plate and put some screws in? Absolutely, they know how to do it. But do they appreciate the nuances of the technique? No. The other thing is, and we've kind of talked about it before, is that this is not a super common condition, right? So if you don't train at a center where you have an where you have endocrine support, where you have like an XLH clinic, and our clinic is not an XLH clinic, but it is pretty predominant in the clinic. So, so if you don't get that experience in training, then you have somebody that walks into your office, you may or may not be super comfortable, and you probably are gonna refer them out. So technically, every orthopedic surgeon can place this implant, technically. But it's everything else that's associated with it that is important, and you're only going to get that in big centers.
So how many ricket clinics are there that come together for this type of training?
I know we have one here. I really don't know.
That's the right answer.
Yeah.
That's the right answer.
I mean, and what I said too, and kind of the whole point of my talk is do all this stuff and everybody oohs and ahs over it, but really my part's one, easy, and two, is totally dependent on what happens in our rickets clinic. So I actually have my clinic schedule set up now where there's a rickets clinic on, it's the 4th Friday of the month, it's in Friday morning. I have a clinic in the afternoon, so I am rapidly accumulating a lot of children, but part of the reason I did that is because I'll wander down there before the end of the rickets clinic and kind of look around and say, you look like you may be getting time for some surgery. But if you're just presenting as a new patient, then I don't want to operate on you just yet unless you're like 10 years old and have no growth left, because I'm going to let you get some metabolic control. And am I the best person to assess metabolic control? Absolutely not. So then I kind of look over to my counterparts and say, what do you think? And then I listen. I say, you know, if Dr. Rupi thinks I need to wait another 6 months, I wait another 6 months. You know, there's a few kids where clearly they're bowed enough and they're old enough that I got to do it now because I don't have a chance if I don't go now. But on the younger kids, you know, it's a very delicate interplay of when is the right time, and so you need to have that cooperation. Yes.
So are the days of full-length leg braces and leg splints gone?
So what we know about bracing. So for genu varum, for just bow legs, bracing is not gone. What we know about bracing in XLH, in other ricketic conditions and skeletal dysplasias, it doesn't work. It's just torture. It really, it's so for a diagnosis specific answer, yeah, they're gone. But in general, you know, I clearly had nothing to do with that. It was, but we have figured out they just don't work. They don't work. They work well in Blount's, for example, like we talked about in theory. And actually, in perfect practice, in perfect use, they work well. The problem is that typical use of leg braces is really poor. It's really poorly tolerated. They're long leg braces. The braces we use in Blount's, the knees don't bend. And we're using it in kids, you know, 2 to 3 years old, so they're potty training. They're in daycare. The daycare workers don't want to mess with them. The kids can't even sit on the floor. You know, they're all told to sit crisscross applesauce now. The kid can't sit like that for story time. You know, anytime you have a little boy in braces all the way up to here, you know exactly what's going to happen with them. About half the time with little girls. So it's just, you know, typical use of bracing is hard, and it makes the results not as good. But if you can get a situation where you can have perfect use of the braces, they do work in those conditions, but not when you have a metabolic bone disease. Yes?
Generally with XLH, of course, your bone will heal slower than in a surgical procedure than, you know, in other variable conditions. So say you have someone with osteotomies and the healing is a little bit slower. What are your recommendations with things such as like a biomed or exogen, some sort of like bone stimulant?
So, you know, so we're talking about delayed unions, non-unions. There's a couple of reasons why you have a delayed or a non-union, and it's either stability or biology. So in osteotomies that we fix with plates, and even with nails, we have excellent stability. So stability is not normally the problem. Biology is the problem. So why can biology be a problem? Well, if you have an open fracture, for example, and you lost all the good stuff there, and you have, you know, grass and road on your leg, clearly biology is a problem because we have to wash that out, and with that we wash out all the good things the body has. Biology can also be a problem because you have a metabolic bone disease. Even when we treat the metabolic bone disease, the defect in the mineralization is still there. And that's the biggest problem we face. So bone stimulators, I mean, we talked about risk-benefit before. The risk of a bone stimulator is like 0. I mean, I guess maybe it could malfunction and burn your leg. I haven't ever heard that happening. The other risk is they're expensive, but really the risk is really low. And the potential benefit is there, that it may stimulate whatever biology you have to work a little bit better, then yeah, I don't have a problem using it. It's generally not as big of an issue in kids. Kids just heal a little bit better. But you know, it is an option, but it's not an option where I would go and hang my hat on this is going to fix the problem. Because if we have a problem and we're getting to using a bone stimulator, I'm already pretty nervous. So.